passionate, active, and young faculties in the country, Dr. Parul Raina, to throw some light on a very important, less discussed, but most important topic, delirium. And I invite, without much delay, Dr. Rata Venkatesan to formally introduce the faculty and further take up the session. Ma'am, it is over to you.
Thank you. Good evening. Welcome, big welcome to all of you. As Sri Priya was mentioning, we are more than halfway through. So we have been dealing with various symptoms. Each symptom is important and some are more unique to palliative care. And one such is what we're going to discuss today. Because once the symptom is recognized well, it can be treated, and then it gives a big sigh of relief to the patient and the carers. You will know why I have said that as we go through the session. Let me not steal the importance of that. For that, I do welcome Dr. Parul Raina, who is Assistant Professor, Department of Anesthesia at Sharda Hospital, Uttar Pradesh. She has graduated from Belgaum, Karnataka, and completed her MD anesthesia from Jammu in 2019. And after her senior residency from AIIMS Delhi, she's working as assistant professor at the Sharda Hospital, Uttar Pradesh. And she's also a fellow at the Global Fellowship Program in Palim, India, in palliative care. Her keen interests are chronic pain and palliative care. Chronic pain and palliative care go very well hand in hand. As all of you may be aware, I've been telling this again and again like a parrot. Pain and breathlessness are very, like they cover 80% of the symptoms whenever you deal with palliative care. And so these two, chronic pain, whoever deals with chronic pain will easily gel into palliative care. So with that, I hand over it to you, Dr. Parul Raina, to take us through the session.
Good evening, everybody. Thank you so much for inviting me and giving me the opportunity. Without much any ado, I will share my screen. Just a second, I'm finding a little bit glitch in the sharing screen.
Sri Priya, she has permission to share. Please check that.
Permission is already there.
Okay. So you should be able to.
Just let me see, try.
Try once again, and if not also, Sri Priya can do it from their end.
Okay, I'm finding difficulty. Please share the slides. Yeah.
Yes.
Yeah. Good evening, everybody. The today's session topic is delirium. Next slide. Yeah. So the word delirium, it is derived from the Latin word delirium, which means go out of the furrow. It is the most common neuropsychiatric disorder in patients with advanced illness. And the most critical features of delirium are it is acute in onset and the symptoms are fluctuating in nature. It has a very high prevalence of 13 to 93%. Though delirium is reversible, but not in all cases, especially in advanced illnesses, where it is a sign of an impending death. And almost 100% of the patients will have delirium hours to days prior to the death. Not only it is a problem for the patient, but it is a distress for the family members, staff, and even can interfere with the recognition and control of other physical symptoms such as pain. Next slide. Before coming to the clinical features, I would just like to know among all the participants if they can say or they can use a chat box where all have this seen in the cases delirium in their own practices. Can you just list them? I will start ICU patients. Where else? Okay. Yes, wards also. Yes. 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 In old age patients, withdrawal patients, ICU patients, and even in post-op patients. Yes, good. Next slide, please. So, yeah, I'm seeing the chat box that it's coming. So, yeah, so making the class easy for me. Thanks. I will continue. So, the delirium is diagnosed from the diagnostic and statistical manual criteria, diagnostic criteria, where all of the criteria should be present. Let's be diagnosing a patient with delirium. So these criteria are: number one, disturbance in attention, that is the reduced ability to focus or shift or to sustain attention. Number two is disturbance in awareness. There will be a reduced orientation to time, place, and person. And also there will be a disturbance in cognition, like memory deficit, problem in language, or perception. Importantly, one has to remember this is occurring for a very short, it is happening at a very short period of time with a sudden change from the baseline. And in fact, it fluctuates during the course of the day. One has to remember that this disturbance in attention and awareness, they are not explained or established by any existing or evolving neurocognitive disorder. Also, there should be evidence from the history, physical examination, or lab findings that this disturbance is a direct physiological consequence of any other medical condition, like substance abuse, substance withdrawal, or exposure to a toxin. Next slide. So depending upon the clinical features, delirium is subdivided into hyperactive, hypoactive, and mixed variety. In hyperactive, it is predominantly restlessness and agitation, whereas in hypoactive, it is predominantly drowsy and inactive. And in mixed subtype, there is evidence of both hyperactive and hypoactive features in the last 24 hours. If I can ask, among three, what do you think will be the most common thing, common delirium, type of delirium? Whether it is hyperactive, it's hypo, or it is mixed. Okay. Dr. Harni is writing hyper, Dr. Madhu is also writing hyper. Dr. Anupama is writing mixed. Actually, it is the hypoactive variant. But the thing is, it is commonly mistaken for depression or dementia. That is why it is not recognized early and it is managed late, hence the poor prognosis and outcome with the hypoactive delirium type. Again, I am emphasizing on the fact that it has a fluctuating course that results in the lucid intervals. So if you're only going and assessing a patient at a one point of time in a day, that patient might be in the lucid interval and there are chances that you're going to miss the diagnosis of delirium. Hence, again and again, and review assessment is very important in identifying delirium early. Next slide. Why do you want to know the differential diagnosis? Because many of the times we confuses delirium with anxiety, psychosis, and hyperactive delirium, especially as depression. If we are not making the diagnosis correct at the early phase, we won't be able to treat delirium. There is a common misconception, or we can say the confusion regarding the differences between delirium and dementia. Can anyone just write? I want to make it a little bit interactive. That is why I'm asking questions. Can anyone just jot down a few points? What do you think can be the differences between delirium or dementia? Anyone can speak also. Okay, dementia is loss of memory. Dementia is progressive. Yes, Dr. Gurinder is saying dementia is not acute. Very correct. Whereas delirium has an immediate changes from the baseline. Yes. Delirium has all the component. It has orientation, cognition. Yes, Dr. Anupama is writing it is primarily memory. Delirium, that of attention, orientation. Yes, delirium is acute illness. So yeah, I've got plenty of answers. Thanks. Let us see now, let us summarize the differences between delirium and dementia. Next slide, please. So yeah, as you all have rightly mentioned, delirium is abrupt. It fluctuates, as I've already told, and its duration is hours to weeks. Whereas dementia, it is mostly insidious, has a slow decline, and duration is from months to years. Attention, sleep-wake cycle, orientation, behavior, speech, thought, and perception are commonly impaired in delirium. It is also not initially impaired in dementia. It is quite intact in the initial phases. The most important point one has to remember is the level of alertness. It is impaired in delirium, whereas it is normal in dementia. Next slide. Coming to the etiology, various studies have been done, are still in a process to identify the predisposing factors so that we can control the delirium in the initial phases. So there are various factors or various causes, predisposing factors, which along with the precipitating factors leads to delirium. And delirium has a very poor health-related outcome. Next slide. So we have a list of predisposing factors and precipitating factors. As in the beginning, some of you have mentioned older age, polypharmacy, and coexisting medical illnesses, surgery, physical frailty, visual or hearing impairment, past history of delirium, dehydration, and even dementia or cognitive impairment earlier makes the patient predisposed to have delirium. Along with that, the precipitating factors being polypharmacy. Patient is on multiple sedatives, narcotics, anticholinergics, and also anti-Parkinson's drugs, corticosteroids, overdose of tricyclic antidepressants, systemic illnesses like acute illness, infection, cardiac illness, neurological injury like stroke, intracranial bleeding, meningitis, surgery, especially orthopedic surgery, hip fracture and delirium. They have found a very strong correlation in various studies and literatures. Environmental factors are also equally important. Many of the times,
We have lost contact with her, maybe.
Yes, ma'am, I also think so. Let us wait for a minute.
We'll wait. We'll wait a few minutes.
Could everyone heard me? Like when I was mentioning the precipitating factors?
You were not audible for the last few seconds, maybe.
Okay. So I was mentioning the surgery, the orthopedic surgery. Has anyone discussed the precipitating factors? I actually didn't realize that no one is able to hear me. So let me come back again to the precipitating factors, as it is like drugs, primary neurological injury, acute illnesses, metabolic abnormalities like hyponatremia, hypomagnesemia. Surgery, especially orthopedic surgeries, hip surgery, has found a very strong association between delirium. Environmental factors, I was mentioning that use of physical restraint, use of catheters, invasive monitoring, even intensive unit stay can also precipitate delirium. Untreated pain and prolonged sleep deprivation can also trigger off delirium. Next slide, please. This is a summary of the triggering factors which I've already discussed. Factors like metabolic abnormalities, a side effect of chemotherapy or radiation, infection or sepsis, dehydration, hypoglycemia, hypothyroidism, medical conditions like alcohol withdrawal, nutritional deficiencies, metastasis, stroke, multiple organ dysfunction, polypharmacy, and including systemic illnesses that will lead to pro-inflammatory cytokine release can also trigger off delirium. Next slide. This is just the summary of the triggers for the delirium. I just had put it this so that it is easy for you to remember. There was some study where they were assessing the various triggers for the delirium, and they call it as DINS +5 framework. D stand for drugs, I for infection, M for metabolic, S for structural and systems, P for pain, L for liquids and solids. Importantly, always remember urinary retention and constipation. Don't forget to ask the patient their bowel and bladder habits, because they also can lead to delirium. Senses like uncorrected vision or hearing or communication deficits, deprived sleep, unfamiliar environment, lack of family presence, restraints, and psychological distress. These all are listed as the triggers for delirium. Next slide, please. So what it can lead to? It can lead to distress to the attendants, to the caregivers, and to the healthcare staff. It will result in increased mortality, greater length of stay at the hospital, more hospital-acquired infections, falls, and incontinence, especially in the hyperactive delirium, whereas hypoactive delirium has very less chances of less reversibility and with a very worse quality of life. Next slide. There is something delirium destructive triangle, and it is very important to understand that when a patient is in delirium, it will result in distress to the relatives and the caregivers. And what they do, they in turn will pressure up the healthcare staff that their patient is in distress, their patient is not doing okay, probably patient is in pain. And in that anticipation and distress, that will result in polypharmacy. Rather than reducing the opioid dose, they tend to change and add on more and more opioids, and that all will lead to opioid toxicity. This will result not in the reversal of delirium, but more agitation. And in terminal delirium phases, it can lead to a very difficult bereavement process and complicated grief among the caregiver settings. So it is very important to address the delirium and discuss it with the relatives and the caregivers. Next slide. The main goal of the management is the comfort of the patient. Inform and educate the caregivers, give them assurance, try to find their apprehensions, and then proceed and manage the delirium accordingly. Importantly, wherever, whenever possible, try to find the underlying cause and correct the correctables. We have to look for the offenders like urinary retention, constipation, and pain, and simultaneously address those issues. Next slide. So the number one in management is early identification. As I've already mentioned, delirium is ideally and importantly only diagnosed clinically, that with the DSM-5 criteria. There are various tools that are being studied and under use to identify the delirium. There are tools like 482, which takes approximately less than 2 minutes. There is CAM tool, CAM ICU, DRS R90. You must be well versed with mini mental state examination. And there is something called a single question squid test. Among that, the NICE guidelines have usually recommended this 482 in assessing and early identifying the delirium. But in majority of the setting, CAM and CAM ICU are well validated. CAM can be used in the post-operative setting, and CAM ICU are definitely used in the ICU settings. Next slide. Yeah. So important point is not to just see the patient only once and diagnose, okay, this patient has delirium or this patient doesn't have delirium. You need to review and review at least twice or thrice a day, every 24 hours, and document. Next slide. So this is regarding the 482. I just thought that I will go through this. So the 480 tool has 4 A's: alertness, AMT, attention, and acute change or fluctuating course. In alertness, you will see that the patient is drowsy or fully awake, and you will score them. If the patient is normal, it is 0. With very mild sleepiness for less than 10 seconds after waking up is 0, whereas clearly abnormal has a straight point of 4. In AMT4, we have age, date of birth, place, and current year. If the patient doesn't make any mistakes, it is 0. 1 mistake, 1 point. 2 or more mistake, 2 points. For attention, you will ask the patient to tell the months of the year in a backward order. We'll start from December. If the patient can say 7 months or more correctly, it's fine. If the patient starts but scores less than 7 months or refuses to start, it is 1. If you cannot start because the patient looks drowsy or inattentive, the score is 2. And important is acute change or fluctuating course that is arising over the last 2 weeks and is still evident in the last 24 hours. If it is yes, then it's straight 4 point. Next. So the score is like, if it is 4 and above, it is possible delirium. If it is 1 to 3, possible cognitive impairment. And whereas if the score is 0, it is very unlikely. Next slide. This is the list of various detecting delirium tools for detection assessment. As you can see, the 480 tool has a sensitivity of 86 to 100%. And we don't require any training. There is also MRAS score, the second last line, where it can also be used in multiple settings, and it can also be used even to assess the severity as well as for monitoring purposes. I don't want to go into much details of all of the tools. Yeah. Next slide. So yeah, coming to the basic clinical diagnosis and assessment, we'll go with the investigations. Investigations, it is important to remember, whenever possible, we can go ahead with the investigations. But in cases where the patient is at the terminal illnesses, try to minimize as much as investigations are possible. But yes, whenever you are trying to find the reversible causes, we can do the investigations. We can do a simple CBC, metabolic panel, thyroid profile, a simple ABG, urine analysis, ECG, and in case you are suspecting any neurological system abnormality, you can do a CT brain. Next slide. After diagnosis and identification, the important point is risk reduction, where the non-pharmacological management plays a good amount of role. So in that, we have to remember what all the precipitating factors that we have listed earlier. Those factors keeping in mind, we will see how these risk reduction strategies that can be done. We have to minimize the use of immobilizing catheters, IV lines, and physical restraints until unless patient is not harmed for himself or the surrounding surrounding people, we have to avoid the physical restraints. We have to monitor the nutrition. We have to avoid immobility and promote early mobilization, provide visual and hearing aids, manage the pain, monitor fluid electrolyte balances, monitor for the bowel and bladder functioning, and always review the medicines which the patient is already on and look for the offenders if there are any. We have to improve the orientation communication with the patient. You can do that by surrounding the patient or calling in the caregivers to be around the patient. We can facilitate sleep hygiene. We can improve the daylight interventions at bedtime by minimizing the noise and keeping the room dark at night, and try to not to interrupt the sleep, and try to not to do any investigations during the sleep hour time of the patient. Very oddly, one does the investigations or EBG sample early morning in the ICU. All these things and interventions at the bedtime have also a role in leading to delirium. Next slide. After non-pharmacological, in pharmacological risk reduction, it is that all the patients whom you are considering at risk of delirium, they should have a medication review. And you have to identify the areas with patients at high risk of delirium, such as trauma orthopedic wards. They should have protocols for commonly required medications like analgesia and anti-emesis that contain choices for first-line treatment, which in turn can minimize the risk of causing delirium. Next slide. Coming to the treatment per se, it is very important, along with the non-pharmacological methods, we have a pharmacological treatment. If the all other methods, like you have tried to reverse the cause, you have to identify the cause, and still you're not able to manage the patient, then pharmacological treatment plays a good role. In that, the first line of drug is haloperidol. It is given in a very low dose, starting from 0.5 to 3 mg. We can either give perorally or subcutaneously. Always start with the lowest dose, and it can be given at bedtime or twice a day. Review the patient next day, assess the patient, see the patient has improved or not. Again, try to find the reversible causes. Along with the pharmacological treatment, manage the non-pharmacological management aspect as well. If the patient doesn't require, taper off the drug. If the patient still is requiring, we can continue the drug, or we can even start the infusion doses, which are generally less than 10 mg in 24 hours. In the next line, where the anxiety is the main predominant component, we can add, or we can even start benzodiazepines in those cases. We can use olanzapine, lorazepam, midazolam in a dose of 2.5 mg to 5 mg subcut. All these drugs that can be given in, especially in cases of alcohol withdrawal, as a sedative, as an antidepressant withdrawal management, and also in Parkinson's disease, where haloperidol is generally avoided. And in cases where the patient is at the terminal phase and we require more of the sedation part, we can start the patient on midazolam infusion, or we can switch the haloperidol to levothyroxine 6.5 to 12.5 mg subcutaneously. Levothyroxine has a very sedating properties, so this can be used at the terminal delirium stages. Next slide. So, not to go into detail, here is a list of various typical antipsychotics or atypical antipsychotics that can be given. As I've already mentioned, there is haloperidol, chlorpromazine. In atypical antipsychotics, we can use olanzapine. And olanzapine has a major role in sedation. We can also use quetiapine. Quetiapine is predominantly useful in patients who, along with the delirium, have like a disturbance in the sleep-wake cycle. Also, we can use ziprasidone or aripiprazole. Next slide. Yeah. In the off-label treatment of the drugs, we can use, they have been earlier used melatonin, but it has shown a very poor evidence. And now the drug which is coming up is dexmedetomidine. It is a centrally acting alpha agonist, and it is commonly and majority studied in the ICU setup delirium. And it has shown wonderful results. It can be given in infusion in 24 to 48 hours. But in the ward setting or in the home care settings, we still need more studies to recommend this drug. Next slide. So if anyone have any doubts, you can ask, because I'm at the end of my session. And what I'm going to show now is the study which was published in 2021 in Palliative Medicine Journal, where its authors have done a systematic review and wrote down the experience of delirium in palliative care setting for patients, family, clinicians, and volunteers. Next slide. I just leave it for you all to go through that, and I'm not state these statements. The purpose of showing these statements is to reinforce the fact that never leave the caregivers behind whenever you are managing a patient of delirium. Next slide. Also, important point is that delirium is seen as a normal part of time. And though it will offer some reassurance to the family, but it often acts as a barrier to the clinicians who actually want to look for the modifiable causes and try to manage the delirium. Next slide. It's not only a great deal of distress to the patient, but to the caregivers and especially to the healthcare workers who are managing such patients. So yeah, we are going to the last slide. So are you all delirium ready? This I've adapted from the Google, already for the owners are Dr. Rebecca and Dr. Manu Krishnan. It has beautifully summarized the whole delirium in a very beautiful and by doodle form. So yes, by delirium ready, we have to suspect it. We have to spot it by assessment. We have to find the cause. And we have to stop it or we have to prevent it. Yeah, that's all. Thank you.
Thank you very much, Dr. Parul Raina. Amazing. See, as I mentioned initially, this is something, um, a symptom. Normally, when patients present with it, something is abnormal, patient is not all right. Those are things, but it's something. It's also a disease or symptom which has to be, mostly it is said as psychiatric. No, it has to be picked up properly, as you summarize, identifying it. And once you sort it out, the patient and the family, more than the patient, the family will be so much relieved.
Yes.
And many times, like sometimes on also like without, with unintentionally, they can even harm someone in
Yes.
those states.
Yes.
See, I'm also someone similar to you. I'm also an anesthetist, done chronic pain for many, many years in intensive care. So we have seen a situation where one patient in his peak state of delirium, he didn't know what he was doing. He just went up to uh, go to the patient who was just opposite to him. So we had to control him, and with two nurses, I had to literally give him IV medication to bring him down, calm him. That's all. So then, when he became all right, he was like, "Oh, did I do it?" So these type of situations, identifying and correcting it will give so much of what to say, relief to the family. And once they see their loved ones back normal, it's just like fever or cough cold, like that only. This is also something. But and haloperidol does wonders. That's what I would say.
Yeah, rightly said, ma'am.
It's just even like 2-3 doses, it will be a totally a different person.
That we
And
will have to review.
and then next thing is that similarly in end of life care also, haloperidol does help, and even in that last minute delirium also it is very helpful. There you will need it to be given on a regular basis. And there also it, because again in that situation also, the family, they don't want to see their loved ones struggling.
Yeah.
That's what dignifying every second of a person's life. So delirium is something which is, it is also equally important symptom once it is picked up well, managed, and it can be helpful for the patient and family. And as we went through, they were all quite, the chat box was filled with all queries. It was nice, very interactive. Yes, and then see, and then your compare contrast dementia delirium is another important thing, which many times it may go hand in hand also.
Yes. Yes.
So again, in dementia also they can be pleasantly confused, they can be violently confused. It could be different types.
It can be super added delirium as well over the dementia.
Exactly. So that's all. So these are things which may be interwoven. So picking them up, and any burning queries,
Yeah.
please
Somebody has raised
go
the hand,
ahead.
Dr. Meera.
Yes. Please unmute and speak.
Brogan here. I was wondering again, one of the slides when we talk about delirium management, the first and the primary thing is to comfort the patient.
Yeah.
Apart from the pharmacological intervention, haloperidol, benzodiazepines, plus talking to the patient's party or the family members, that is understandable. Apart from that, what measures do we have to comfort the patient, not the family members?
Yeah. So what we can do is we can keep the patient in a very calm room with the in a place where there is less movement around. We can surround the patient with the family members, where the patient can see the familiar faces. We can keep the small items of the familiar items which the patient have at home to make the surroundings more familiar to them. Yeah. And for sleep, we can manage the sleep cycle by keeping the lights off or keeping the room dim in the evening time, and then back to the light phase again in the morning time. These are all the non-pharmacological management that I'm telling. Yeah. As Alexa, ma'am, do you want to add up? Dr. Rapan, yeah.
I think like, it's just my guess. He
Yeah.
was asking, other than restrain, I think that's what he was coming for. Is
Yeah.
that right? Please restrain, other than without doing physical restraint,
Yes.
what can be? Is that right, doctor? Is
Yes.
that what you were coming to? Dr. Brogan?
It's not about the restaurant, as Dr. Parul was answering. Yeah, some of them, it's I think it's quite understandable. But we are talking about a patient who has a temporary or the permanent sort of decline in the cognition, decline
Yeah,
in many other aspects. So whatever we do, that will be sort of our assumption in a way that the patient is impaired. So of course, having those sleep cycle, putting up the light and all, that is understandable that we can do that one. But usually, in terms of the dying patients, again, that was, I was thinking, what else can we?
In dying patients, the only thing is for dying patients, especially terminal delirium, itself is a very separate topic. So actually, we don't have that much of time, so I didn't go in details with the terminal delirium topic actually. In that,
if you don't mind, Dr. Parul, because this team have always been asking about it, and I've been telling them either in one of the sessions if you could just give us a quick, I know it's not easy because we do have end of life care also. We will be touching a little bit in that because they've been asking about this from the beginning, because see, that's also part of palliative care. I've been telling you have subcutaneous infusion, many elements are there in that. So am I asking too much or what? I don't know. If you could just highlight or summarize in few minutes, if you could, please.
Regarding terminal delirium, ma'am?
Yes, please.
Okay. So in terminal delirium, important is that you have to ask the relatives how much they want the patient to be awake, or do they want, because in like especially in the terminal phases, many of the times the relative says that, okay, we didn't have said the goodbye, we didn't say our last goodbye. So you have to assure that, number one, the sedatives which we are giving will calm the patient and comfort the patient, and at the same time there will be periods where the patient will be awake. So in terminal delirium especially, we usually go with the infusions. We can start with the propofol infusion. We can also give midazolam infusion subcutaneously, and we can even use haloperidol for the terminal delirium phases. Yeah, and if you can try to reverse few reversible causes, well and good. But in the terminal phases, usually we don't go for the investigations. So yeah, that's all I would like to tell, ma'am. Yeah, in short.
Exactly. So it as we always say, like we say, goals of care. Okay, it is all what the patient want. That's what we are. First thing, we will explain in any situation. As doctor was mentioning, terminal delirium will be slightly different to a general single episode delirium, because in the single episode delirium, we are just correcting the correctable, and then the patient reverts to normal. That is his normal. Okay, that also we always have to, that's what every word, every situation matters. So they revert to their normal condition at that point of time. Whereas if it is terminal delirium, it's totally a different, another kettle of fish. So you deal with that at that point of time as required. So again, as she mentioned, see, some family, it all depends. See, sometimes they would have been along with the patient. Okay, so they would have been spent their time, and they may say, we want the patient to be calm, comfortable, fine. No, it could be another one. So they've not been with the parent or someone, they've come from somewhere. See, we have to look at all situations, So that time they say, oh, I have not spent time. As she said, I have not seen him alive. I have not spoken to him, something like that. So something what I used to say in intensive care, I would just like to share. See, always we say, even though they are not awakened, we say, just hold on. That's what we say. Hold on to the patient's hand, and they will show signs, grimace. And then you have seen, they may not like open up and speak, but they show so many emotional signs. So we say, and we tell this to patients, and I've had plenty of experiences like that. So as she said, just having them around. So you get the side rails up, okay? If the patient, most of the time nowadays, when the patient becomes bedbound or something, even if it is at home or whatever it is, you make sure that they don't tip and fall or something like that. Those type of safety measures are taken. Okay, so you have all that set up, and then you have, like for example, if you have friends and family or relatives around, you have people around them. So when they wake up or open their eyes, what is the main reason? When they're in hospital, they see bright light, so many monitors, all beeping sound, all that are the disturbance. Okay, do we have all that at home? No, we have some music or some light or something else at home. We don't have that. That's the foreign situation, what they see in hospital. And generally, many patients are scared of hospital. So all this adds on, additive effect happens. So take all that away, bring family around, just have them to hold hand, stand close by, and then talk. And then normally we say, as she said, keep pictures of whom their loved ones. So when they see all that, they think, oh, okay, it's not an alien situation. And then normally in ICU and all, because we have other patients continuously, so you may have this patient, there may be another patient who needs, for example, I'm telling, needs all central lines, doing everything, stabilizing. So you have 10 people working on that. So that is not a nice situation for this patient. So these are things we have isolated, even in intensive care and things, we have some rooms like this. So all these are available. So you do appropriately. Okay, if it's not available, you fine. You move them to a room where you can see. And if it is terminal delirium, we are not going to monitor everything as we would monitor a general patient. So many factors are there. Individual case based thing is what we will consider. And as I mentioned, again, when we have the end of life care session, we will try to deal a little bit more with that also. Hope it has answered, Dr. Brogan. If not, please unmute and
Yeah,
ask.
yeah,
Yeah.
yeah.
Thank you.
Yeah.
And someone has.
I think Dr. Anupama has raised hand sometime.
Okay, go ahead.
Good evening. I
Mm.
just wanted to add what we do in practice. Sorry, we don't. In my practice, I don't deal with terminally ill or delirium terminally connected. So I can't say about that. But psychiatrically speaking, for the delirium cases, we have something non-pharmacological intervention that trumps the pharmacological thing, and there are many papers published on it. We call it the reorientation therapy. So in reorientation therapy, what we do is we make sure that the patient, like ma'am and everyone has already suggested, Radha ma'am and Dr. Raina.
Dr.
Both of
Parul.
them have, yeah, Parul ma'am. Both of them have suggested that we shift the patient to a more calmer environment without all the sounds and cacophony of the ICU. And the second thing is we make sure that the bed is beside a window or at least something where they can see when it's light and they can see when it's dark. So that is orienting them to the time. And like they said, a little familiar environment so that they can get oriented to place. And the other thing that we have constantly observed is that the attendants take it little personally when the patient is not recognizing them. They're like, they're not recognizing me anymore. And people who come to visit just once a week or once in 2 weeks, they're like, they're not recognizing me anymore and it's pointless and all. We tell them that instead of saying, Pachana, Pachana, did you recognize me? You can just go introduce yourself as if you're doing it for the first time. And at the same time, you can say, it seems that you have been here for a while because of this problem, but it's all right. There are doctors and us trying to help you. And I am so and so person, and today is this is the day, this is the date, and this is the time. And I came to know that you had something like this for breakfast or lunch, whatever was the preceding thing. And this we try to do it every second hourly now. Like we schedule it with the attendants and the relatives, and we explain them that it is a hand-in-hand process, and both of us together can help the patient instead of just taking the whole burden. And the second thing we do is we also do the reorientation therapy whenever we go for twice or three times based on the severity of delirium, the rounds. And believe me, there were old age people who were in delirium that we have handled for 3 months, 3.5 months also, but they do come back. It's not lost. It takes time. That is my experience. I know it's very short. I think hardly I can say I've handled some 20 or 20 odd cases of delirium in my life till now, but yeah, that was my experience.
Yeah, thank you, Dr. Anupama.
Yes, thank you, Anupama. That window thing, very useful.
Yes.
Next thing, what we used to do, same like a window, what we used to do, once they're okay, if they can sit on a wheelchair, we just try to get them on the wheelchair and take them little. In our ICUs, we used to have a small way where we could and take them outside once they are a little bit stable, to show that, see, because ICUs are just close setup, everywhere only walls and light and things, many times windows. So we used to just take them, this window thing, thank you very much, because just literally day night orientation, circadian rhythm, all these we say. So that is, and introducing rather than asking, that's something very good. Okay, nothing wrong, isn't it? Why should we question them and say, oh, they didn't? We can say, oh, I'm so and so, nothing like that. So give less burden for them. See, when they are going to become all right, they will recognize they are in the phase of recovery. Very good. Thank you very much, Anupama. Shall we go on to the case discussion? Let me check the chat box. Oh, no, there's nothing else in the chat box.
Yeah.
Shri Priya, can we go on to the case discussion and then let's come back?
So good evening, everyone. I'll be doing the case presentation about a case of delirium that we've had, that we have managed in our institute recently. It is a 41-year-old male who is with a diagnosis of alcohol dependence syndrome. He presented with withdrawal state in delirium, and there were no convulsions at the time of presentation. ICD-10 diagnosis code would be F10.40 for this patient. Next slide. Presenting complaints, he presented with complaints of inability to recognize family members and surroundings, irrelevant talk about multiple known and unknown people who are coming to harm or kill him since yesterday night. And he also had difficulty in initiating and maintaining sleep since the past 4 days. He was unable to eat food properly for the past 4 days also due to nausea. And he is continuing to drink alcohol, albeit in reduced quantity than his usual, despite the presenting complaints. So apart from the presenting complaints, I just would like to throw a little light on the patient's history. If you can go to the next slide. That he is a very chronic alcoholic who has been consuming it for more than 20 plus years. And this is not his first bout of presentation at our hospital. So even despite his physically and mentally ill states, he still continues to drink. So just to paint a picture, the alcohol bottle is always beside his bed. He gets up, he drinks a little, and then he again goes back to sleep. And whatever ailments or whatever occurs, it's for the wife to recognize and then bring him subsequently to the hospital. Next slide. So, like I said, he's a known case of chronic alcohol consumption. He's also a diagnosed alcohol dependence. And like I said, he also has early morning drink, daytime drink. In the middle of the night also, if he awakens, he just goes and has a drink. And he is under treatment on and off for the same at our institute since the past 4 years. Multiple relapses, craving. So what were the reasons for him continuing to keep going back to alcohol despite his admissions and our treatment and interviewing and counseling and therapy, everything is that he had craving and pure cue control. So one of the major things that predisposes a person to go back to alcohol after abstinence is what we call cue control, the smell, sight, taste, or even the place where they used to sit and consume alcohol. If they come across it, then the craving is triggered and then they go back to the same tendencies. So he has been treated in our institute prior to this episode for 4 times, and out of those 4, already twice were delirium, and one was convulsions, and one was a simple withdrawal state. And this is the 5th time he's been treated. Next slide. On examination, temperature, pulse, blood pressure, and SpO2 were normal. His gait and general physical examination were normal, apart from the tremors. And central nervous system examination, we couldn't completely do the cognitive assessment and the higher mental functions because of the delirious state. And mental status examination, he had fluctuating orientation. So when he presented, he was disoriented, and also, but it was reported, like it has been told during the presentation, that he had lucid intervals. The lucid intervals were more during the day, and the delirium used to worsen towards the evening or the night. Something we call the sundowning phenomena. And eye-to-eye contact was poor, rapport could not be established. Speech was spontaneous, it was coherent, but it is irrelevant. He was in his own mind, and he was speaking to his hallucinations and responding to them. It was inappropriate, hallucinatory behavior was noted, and auditory hallucinations were present. Secondary delusions of persecution to that patient was actively quoting out that don't you dare come harm me. And a wife has reported that at one point of time, he started hiding a knife behind his pillow of the fear that if someone attacks him, he can attack them back. Next slide. Treatment, patient was admitted for further management. He couldn't be handled at home. Following investigations were done to both assess organ functioning and to rule out the other causes of delirium. We have multiple times come across a lot of multifactorial cases of delirium, even though it's quite cut and clear that alcohol and withdrawal state is the predisposing factor. We do always investigate because for the past 4 days, he has not been eating and sleeping properly before the onset of delirium. So there might be something as simple as dehydration and dyselectrolemia also that can worsen the delirious state. So we make sure that any delirious patient who is presenting at this stage has the whole bout of investigations. So in his, we have observed that AST, ALT, and GGT on LFTs were raised, and raised levels of amylase and lipase, but not in an acute phase. And rest all investigations were within normal limits. There was no dyselectrolemia especially. Next slide. Psychosocial aspects for this patient, he had multiple relapses. He was unable to maintain abstinence to alcohol. He was unable to hold a stable job due to the same. He would often show up at his workplace in a drunk state, and he would be removed. Wife is the primary breadwinner of family. She has 2 sons, 13 years and 7 years respectively. Elder son, who is 13 years of age, has already started experimenting with tobacco and alcohol. Mother is more worried for kids and finances than husband. If he drinks, he eats and sleeps, does not shout on kids. I can do more work and earn for myself and my family, she says. Is constantly asking for help for the 13-year-old kid whenever she visits hospital. The kid who has been examined, he denies and lies about his habits and is refusing to come to hospital anymore. The 13-year-old kid. The medications that were given to the patient itself, he was treated for his delirium and withdrawal symptoms as per standard protocol. So we started him with replacement doses of benzodiazepines depending on the amount of alcohol he was consuming, converted alcohol units. And also we were adjusting the doses based on his CYR score rating. And anti-craving medications were restarted once the patient was out of delirium. Rehabilitative and vocational services were advised, but we didn't have any such contacts at our place to give to the wife. Q control techniques were separately discussed both with wife and patient itself. And motivational interviewing was attempted for son. He was still in strong denial. Next slide. Main concerns regarding this case is to keep patient away from alcohol, to engage or employ and create a daily schedule so boredom and company does not lead to continued alcohol use, to make wife aware of codependency, and to prevent the elder son from developing dependence to multiple substances. Next slide. Summary, Mr. M, a 41-year-old male, educated up to 5th standard, married, unemployed, belonging to rural background and low socioeconomic status. Case of diagnosed alcohol dependence syndrome, came in delirium and withdrawal state. Patient was treated according to standard treatment protocols and delirium resolved in 3 days' time. He had previous history of multiple relapses and alcohol dependence is the main reason he cannot hold a stable job. The company he usually hangs out with and his workplace colleagues are all habitual drinkers, and patient has poor Q control as well as craving. Wife is the primary caretaker of family and has codependency in that she is also dependent, that our husband is dependent on alcohol so that he's not creating problems at house and he's just sleeping at home. She's also worried about her 13-year-old elder son who is already experimenting with tobacco and alcohol. Next slide. Discussion points for the patient: a stable job, preferably in an environment that is not conducive to any substances of abuse. And for the son, a supportive educational unit that is also monitoring of child's predilections and in a non-judgmental way. Thank you.
Hi, Dr.
Thank you, Dr. Anupama. Really good that you brought up, and both are equally important. He's only a 41-year-old. Okay, so
Yes.
to
And he
see,
has already had 3 episodes of delirium. In our medical conditions, like once the delirium is repetitive, it usually leads to early cognitive impairments later in life.
exactly, that's what it is. And then this 13-year-old, this is the right, wrong age or whatever you can say, because if you don't catch and correct that child needs, like as you said, and a place where, like, this family or the child will need monetary support, giving awareness, education, everything to show that what he's missing, and then taking him in the right path. So will you not be able to connect to any some social service network or something who can help that child out?
Ma'am, as of now, we are in the Ramnagara district of, our medical college is located in Ramnagara district of Bangalore. Here we are trying to find, but I couldn't personally connect to any social services or units that can take up this job. What I did advise to the mother was to put him in a little stricter environment in a hostel, maybe because he is coming home every day and he's seeing his father in a drunk state. He thinks it's normal. So he'll start experimenting early. It is expected genetically also and environmentally also he's predisposed. So the one thing that I could advise her was to put him in a little stricter environment school-wise so that he's just visiting home instead of continuing to stay at home. She said she will try.
For that, she needs financial support, isn't it,
Yes,
to find
yes,
a school. So that
yes.
is why I said, finding a social worker or someone, because they will have contacts to teams and organizations who will be able to, there may be a school or something which may take these type of children with less impact on money. So
Yes.
that is what. Okay, we'll just wait for, like, I'll check what's in the chat.
I would really like to
Go ahead, please.
add-on was like there is something called as family therapy, or because what I found was that the wife, since as you already mentioned, she's in codependency. She thinks that her husband, since he drinks and doesn't create any ruckus, it is well and good. So let it be.
Yes.
But the problem is patient's alcohol. It started everything. So there is a cycle. I think for that you need I believe, a counseling session with the patient and with the wife and with a 13-year-old kid. These 3 people, because the other kid is quite young.
Yes,
I believe these three of them, a therapist, a psychologist, sit through them, find out what is triggering, as you have rightly identified, the friend circle, where he's going, where he was working. We have to find out what is more, like we have to find out the small triggering factors that is leading to all this cycle which is happening here. I think a therapy session with the patient along with the wife in the same setting, and I also, as you were trying to counsel the son as well, probably more and more sessions, like motivation to come to the hospital and to speak with him, because we have to see that where is he finding the source of tobacco and alcohol.
That question actually triggered his resistance. So the
Ah,
question was, how is a 13-year-old able to get beer
you have to
and
ask
cigarettes,
his
and who is
mother.
giving it to
Yeah,
him?
yeah, yeah.
So when we asked that question, he immediately froze up and he was like, not
Okay.
coming to the hospital anymore. So I have the mother's number. We
Yeah.
don't have a psychosocial worker or a support system in place
Okay.
yet. We are a very new institute, but
Okay.
we are trying to. I personally try to call her up and try to find out what is happening at time to time as and when possible. The
That's a
family
good
therapy
thing.
sessions that you suggested, ma'am, we did
Yeah.
try that. We don't have an in-house psychologist yet, but yeah, we did attempt a therapy session by myself. And problem is, weekly once when we schedule the sessions, wife was a little resistant because she's the only
Yeah,
earning
I
person and
understand.
she
Yeah.
cannot continue to miss. And he, when he's not drunk, he gives you all the answers that you want to listen to. He
Mm.
says, yes, yes, ma'am, true, true, ma'am, I'll not drink back, I'll not go back. And then hardly a month goes by and then he relapses, and then there is more resistance. So I keep advising the wife also that, see, at the first relapse, the first drink or the second drink, try and get him back instead of letting him go back to a complete full blown dependency again. And then but somehow it happens that, but good thing is we are observing a little more proactiveness from the wife now. It
Yeah.
is being addressed, but actually what I wanted was, if Valium can help, if there is any local unit that we can connect to, because we don't have our own resources, so that will be helpful for both the patient and the son. That was what I was hoping. I know this was a delirium primarily
No,
discussion,
but
but
it is important actually. It is like in continuation with the topic itself,
yes, yes.
because it is more prevalent and it is like more prevalent in all the settings.
At this point of time in our institute, it has become a thumb rule that if the patient is in delirium, first ask for alcohol, history of substance use or alcohol, any kind of psychoactive substance.
You must be having so many patients coming for alcohol
Yes, yes, we
dependency.
have women also. We
We
have
have
men
women
and
as
women equally.
what about bringing them all together and educating them?
Group sessions.
Group
We
session,
can,
Hmm.
yeah, we can plan something like a
because you
sort
can
of
start
a.
with the small groups, but keeping in mind that few people have that stigmas around them, so you have to look for those factors as well.
Group
No,
sessions
the
work
thing
out,
is
ma'am.
that.
When I was doing my
Hmm.
residency, we had a group that would meet and so kind of sort of amongst themselves they pick a leader. So now it becomes the responsibility of the leader. So none of his group people relapse again. So
Yeah.
they used to self-sufficiently handle among themselves. I couldn't facilitate a group yet here. Thank
Because
you
it
for
will be a good
reminding.
support system for
Yes.
No,
even
group.
for the wives.
No, group session will work, as you have said. No, you can start one in your own setup, because the main pluses with group is, even with chronic pain we do, because when they come and sit together, they initially they are thinking they are the only sufferer. So when they see others and when they discuss with them, they think, oh, it's just not me. So they themselves will. So try group sessions. And next few things I was thinking of asking, multimodal management is what will be helpful here, dear psychologists, counseling, and then step by step. And then that being a 13-year-old, little bit tricky element, you've got a pediatric, like it's of pediatric age. But so, with all this in mind, is there any nearby center which deals with alcohol? That is one option. Or do you have any palliative care center or anyone nearby who have social workers and the psychologists nearby to you?
Ma'am, as of now, we are the center that is dealing with alcohol, but we are primarily focused on the
Oh,
biological aspect of it. We are trying to build, like you said, a supportive system. Psychologist is on the top of our list, and once we do get that, in maybe another 6 months, we are hoping to have at least one psychosocial worker also. Like I said,
great.
ours is a very newly established hospital. It started in 2019, so I was one of the few
Uh,
faculty who was there first. We are trying to build a unit, and almost all medical cases are being referred to our unit there because we are a tertiary care center, medical college/hospital. cases are coming to us rather than
So
away.
you're,
And because we are away from the, we are away from the city. We are on the outskirts. So this is a district. For another, I think 12 or 15 kilometers away is one private rehabilitation center.
so just let me correct. Yours is a alcohol center, something like that.
No,
Or
any
what
substance used
exactly
is
substance?
any,
Okay.
yeah, any substance use disorder is directed to Department of Psychiatry at our hospital.
No, so if you're dealing so much with the substance abuse, then psychologist or no, okay, if it's not a psychologist, at least some counseling person at least you will need, isn't it? How have you been managing for this 3 years then?
We do it by ourselves, ma'am. So we are only scheduling the sessions. We are only doing the motivational interviewing and enhancement therapies. We are doing the follow-up treatment as well as counseling part. For now, we are handling both by ourselves amongst the doctors itself. But we have been putting our foot forward for a psychologist for a while now, and I think it is going to happen soon. Now,
That's what
maybe
you have to make sure psychologist and a social worker both you need, because see, especially with this case as an example itself, if you have a social worker who can deal with the wife, she can go see, when the wife can't come, the social worker can go see, the wife needs to earn, she's the breadwinner also. So you can make sure that if you have a social worker will be able to go do the talking, or rather than the wife coming to you, the social worker can go to the wife.
Okay.
So that's why we say minimum is, so when you ask itself, ask for a social worker and a psychologist counseling or someone. See, sometimes you may not get a clinical psychologist, at least you get someone. So these are something better than nothing.
Yes, ma'am.
So that is how. So social worker and some counseling person you need to have. So and then find out if like any referral. See, you may not, if you have a tie up with some center nearby, you can just send referral for them. So that what you cannot manage until you get, see, 6 months. By 6 months, if you leave this set of, that is this family, they may get to a stage, irreparable stage with this 13-year-old, which you don't want.
Yes, ma'am.
Am I right or not?
Yes, ma'am. Agreed.
So that's why you don't wait for it. You find out what are the, like we can ask Sri Priya also if there is any nearby. Karunashraya, will they be able to help Sri Priya? And how far is
I will
Karunashraya to you?
definitely try to get more details from Dr. Anupama. I will just connect with her and fetch more
Yes.
details and see what can be done from our end. Definitely, we will do that.
That is could be done. And how far is if Karunashraya, and then people from there, you go ahead, get in touch with Sri Priya, Anupama, and see, and then get few contacts, and then you personally contact them. Okay,
Yes, ma'am.
so that even if you send referral, and then if the nearby centers, if they have counseling or something, you can refer them, and then we can see what can be done.
Yeah,
Sure, ma'am.
for this case, it's very important.
Because it's 6 months is too long a time. See, already as she has asked, and we don't know if he's getting, see, it will not only be substance abuse, other unwanted habits may also be coming in.
Yes.
Okay.
Yes.
So these are things, as we say, like how is he obtaining? So legal, illegal, all those things comes. Okay, so that's why this is the right time to catch. So poor mother can't have another headache to face.
Yes, ma'am.
Okay, is there anything else in the chat box? Let me check. Someone has mentioned it's more of a social problem. Yes. Sripriya, maybe we can come out of this screen, and anyone can either unmute and ask, or see, like, for example, as Dr. Anupama is mentioning, she's been doing multiple roles. See, that is the challenge that you face. And then, is that a government setup, Dr. Anupama?
No, ma'am. It is an institute deemed to be university. Dr. Chandrama Dayanand Sagar Institute. It is near Ramnagar district, outskirts of South Bangalore, you can say.
Okay, there's a question in the chat. Are elderly more prone for delirium?
Yes.
Age.
Yes, age is already mentioned in the
Right.
predisposing factors.
That's,
I've not gone detailed to the pathophysiology. I thought it was a little bit too much to go too much in the pathophysiology part. Yeah.
any other clarification or anything else anybody wants to ask?
Ma'am, I think we
I'm
have.
going to,
Yeah.
Shripriya, I was about to say, I'm going in, I'm going to hand it over to you.
Thank you. Dr. Parul, it has always been a pleasure personally interacting with you. You started off as a um, participant with us and now as a faculty. It has indeed, it is indeed been a great journey, and thank you so much. And we do wish to have more such interactive sessions with you in future. Thank you everyone for joining in, and yes, we are moving towards the end of our sessions, and with a promise that we will meet again in the next session with another very different topic and an eminent faculty. This is Sri Priya along with Dr. Parul Raina, Dr. Gata Venkatesh, and Mr. Anup signing off from the Tips Eco Hub. Stay tuned for the next session. Till then, everyone take care. Bye-bye.
Thank you.
Thank